Hello, I'd like to welcome you to this GSK sponsored symposium entitled Treatable Traits from Discussion to Action. My name's Professor Neil Barnes, and together with Dr. David Leather, we will be chairing this symposium. Just a few housekeeping points. Please keep your lines muted, and this session will be recorded. Treatable traits is a concept that's been around for a few years and is being increasingly used in respiratory medicine. And we think the time has come from moving this from discussion to actually clinical operation. So we have three speakers to take us through various aspects of treatable traits. The first is Alvaro Augusto, who really pioneered this concept, and he's going to talk about the reasoning behind it. Then Ian Pavord will talk about some of the common treatable traits that we should be identifying and treating in airways disease. And then Vanessa McDonald will be talking about how you can actually operationalize this idea and use it in clinical practice and give some concrete examples of that. And then there'll be plenty of time at the end for Q&A. These are the conflicts of interest. Now, I'm just going to give a very brief introduction to the idea of treatable traits. So let's consider lung cancer. We've traditionally divided this into different cell types: squamous cell, adeno, large cell anaplastic, and small cell lung cancer. And the reason for that is that this histological diagnosis gave us information both about treatment, who benefited from surgery, and about prognosis. But layered on top of that now, we identify treatable traits like the EGFR mutation, for which we would use a tyrosine kinase inhibitor. So we retain the old classification, but we look for treatable traits. And this is being increasingly used in airways disease. The GOLD strategy document says that when we look at exacerbating patients, we should consider this a treatable trait. And it uses a biomarker, the blood eosinophil, as a helpful guide to what treatment should be. We can see this desire to personalize treatment in other guidelines. Here's the Spanish COPD guidelines, dividing patients into infrequent exacerbators, COPD, asthma overlap, etc. The Czech COPD guidelines have gone down the same route, adding in emphysematous phenotype, pulmonary cachexia, and COPD and bronchiectasis, because they feel that these different phenotypes need different treatments. And this is a treatable traits approach. Now, when you get to severe and complex disease, again, you have to move to a treatable traits approach. And we see that in the severe asthma guidelines, where you look for different treatable traits like severe eosinophilic asthma, or atopy, or dysfunctional breathing. And then you, having identified those, treat those specifically. Now, in asthma, the guidelines, apart from in severe asthma, have used a stepwise approach. But as we become more complex and as we need more treatment, we have more treatment options, it's very difficult to maintain that stepwise approach to treatment. And we can see that with the ACOS guidelines jointly published by Gina and Gold, because these have 11 different definitions of ACOS, some using history of atopy and asthma-like symptoms, some using atopy and bronchodilator reversibility. But we and others have shown that these have little predictive value, and the only way through this complexity is by looking for treatable traits within that population. So, as a sort of example, here's an approach to treatable traits. You identify the trait and then you decide on the treatment. So, airflow obstruction, bronchodilators. Inflamed airways with eosinophils, inhaled steroids. Severe eosinophilic inflammation, anti-IL-5 treatment. Atopy, anti-IgE. Smoking, smoking cessation. Lack of physical activity, rehabilitation, and lifestyle interventions. Hypoxia, oxygen therapy. You identify bronchiectasis, physiotherapy, nebulized antibiotics, etc. allergic bronchopulmonary aspergillosis, antifungals, and hyperventilation, breathing retraining. So it's not just looking for things with a biomarker, it's looking for behavioral things that you can change. So for the rest of the symposium, we'll expand on this and see how we can use this approach.
Hello, my name is Alvaro Agusti. I work in Barcelona, and I am very happy to be here with you today, albeit digitally. The topic of my talk is whether or not it's time for a change in the concept of treatable traits. And let me start by showing you one slide that presents the number of publications that are in PubMed until July 6th this year on treatable traits. And you can see that there is a progressive increase in the number of publications on these topics. So it is a topic of current interest. And over the next 10 minutes or so, I would like to tell you a bit of the story of treatable traits. How did they start, and paving the scene then for Professor Vanessa McDonald to tell you where are they now. Probably the story started here in 2010 when May Lanhan and a group of friends well known in the field of COPD wrote this paper. In this paper, the central idea was that in order to address the complexity and heterogeneity of COPD, well known at that time, the strategy should be based on what we call phenotypes, clinical phenotypes. According to that proposal, a clinical phenotype was considered to be a single or a combination of disease attributes that, very importantly, describe differences between individuals with COPD. And these differences need to be meaningful in terms of clinical outcomes. For instance, symptoms, exacerbations, response to treatment, rate of progression of the disease, or death. If you try to express this concept in a graphical manner, one could envisage COPD as a number of different patients with different characteristics represented here as colors. So each circle represents one different COPD patient. And you can see easily that because of this heterogeneity, there are red patients and blue patients and red and green patients and yellow patients. So the concept of phenotype was very straightforward, as shown in this slide. Simply put similar colors together, blue with blue, green with green, yellow and red together. These are phenotypes. This was 2010. A couple of years later, though, I realized that this might not be right, and I wrote this paper entitled Towards the Extinction of Phenotypes. Please note that all my friends by that time abandoned me. Why did I do that? Well, I realized that real life is more complex than this simple color approach, because in real life, patients do not have only one color. This is only one characteristic. They may have 2, 3, 4, or more characteristics that can be combined in different ways. And this was actually the birth of the concept of treatable traits, at least the informal way where treatable traits were born. In a more formal way, a few years later, March 2015, this is a picture in my office in Barcelona, Mike Thomas, Ian Pabord, Klaus Vogelmeier, Elizabeth Bell, and myself got together and tried to develop the concept of treatable traits more formally. And the end result of that meeting, which was later shared with other co-authors, was that first publication in the ERJ 2016. Treatable traits, a way towards precision medicine of chronic airway diseases. And please note that we were very careful not to say COPD. We said chronic airway diseases because we think that the strategy might be applicable at a number of diseases of the airways. In this paper, we define some basic principles of the concept of treatable traits. First, as the title indicates, we thought that it is a strategy that leads to precision medicine for the for the management of patients with airway diseases, which is label free. So you do not need to have a COPD label or an asthma label or a bronchiectasis label or diagnosis before. The strategy is based on the identification of the treatable traits that are present there, irrespective of the label. This recognition can be made based on either clinical recognition, what we used to call in 2010 phenotypes, for instance, exacerbations, dyspnea, or emphysema, but can also be recognized based on a deeper understanding of the mechanisms, the biological mechanisms of these treatable traits. This is what we now call endotypes. A good example is Th2 inflammation, as Professor Pavod will discuss later. Very importantly, these treatable traits can coexist in the same patient and can change with time, either spontaneously or as a result of treatment. And already there, we recognize that there were at least 3 types of treatable traits: pulmonary, extrapulmonary, and very importantly, behavioral and social risk factors too. A year later, the family has grown. The ERS organized a research seminar in Barcelona in February 2017. And the end result of that seminar was this publication, where we tried to be more specific in what treatable traits might be worth considering in clinical practice. As I said before, there are 3 main categories of treatable traits: the pulmonary ones. Here you have a list of some of them. This does not pretend to be an exhaustive list. These are only probably the more frequent and relevant ones, but you have airway smooth muscle contraction, eosinophilic airway inflammation, sputum production, bacterial colonization, bronchiectasis, cough, chronic respiratory failure, pulmonary hypertension, and emphysema. And importantly, each of these has its own specific treatment. If the treatable trait present in a given patient is airway smooth muscle contraction, treatment is bronchodilators. If the problem is eosinophilic airway inflammation, treatment may be inhaled steroids or now type 2 biologics, and so forth. I will not go one by one, but the key concept here is that each treatable trait deserves its own specific treatment. As I said before, also there is an extrapulmonary category of treatable traits listed here: rhinosinusitis, deconditioning, cachexia, obesity, cardiovascular disease, vocal cord dysfunction, depression, anxiety, and probably systemic inflammation. And again, each of these deserve its own treatment: rhinosinusitis, topical steroids or surgery, deconditioning, rehab, and so forth. The third and final category of treatable traits includes behavioral and lifestyle factors, which might not be very biologically based, but are extremely important in clinical practice. For instance, poor inhalation technique and treatment needs education. Not adherence to treatment, and again, education is critical. Of course, smoking and treatment is cessation support and so forth. Living alone, for instance, is an important social treatable trait. The last meeting we had was May 2018, before the COVID era. That was in Melbourne. You can see here chairing Professor Vanessa MacDonald with Peter Gibson and Richard Beasley and others. And the end result of this third meeting on treatable trait was another publication where Vanessa MacDonald and James Fingleton tried to go even deeper into how to apply these concepts clinically in clinical practice. I will not talk about this because Vanessa will do so in the next few minutes. So nothing else from my side. Thank you for your attention. I hope you find this of your interest. Thank you very much.
Hello, my name's Ian Pabord and I'm Professor of Respiratory Medicine at the University of Oxford. And I'm delighted to be talking to you today about treatable traits. I'm going to focus on established, important treatable traits, but at the end, discuss briefly what I think will be important emerging treatable traits that we'll be targeting in the not too distant future. Now, I got interested in this area because of the story of the clinical development of mepolizumab, that is anti-IL-5. Now, many of you will know that this failed initial clinical trials when given to patients with asthma as defined by bronchodilator responsive airflow limitation, when a related outcome measure, morning peak expiratory flow, was looked at the primary outcome. You can see on the left the findings with 2 doses of mepolizumab. But when this drug was given to patients who had the treatable trait eosinophilic airway inflammation, as reflected by a raised induced sputum eosinophil count, and when we looked at an outcome measure which we suspected was closely linked to that treatable trait, that is the occurrence of asthma attacks, very clear evidence of efficacy emerged. And you can see on the right the Halder study from 2009 showing an approximately halving of the rate of asthma attacks with treatment. So it's clear that when we have a system for classifying and thinking about airways disease that results in us nearly missing the very large clinical efficacy of a drug like mepolizumab, we have a problem. Now, it was clear that what we were doing and the reason that we were able to establish the efficacy of mepolizumab is we were targeting a trait rather than a rather arbitrarily defined label. And that the efficacy of mepolizumab, specifically in patients with eosinophilic airway inflammation against exacerbations, suggesting that we have at least 2 important treatable traits driving morbidity in our patients with asthma. So eosinophilic airway inflammation, which is more closely linked to exacerbations than day-to-day symptoms, and an abnormality of airway function. And I don't think it really matters whether this is fixed airflow obstruction or variable airflow obstruction, which I suspect underpins many of the patient's symptoms and is more closely linked to that clinical problem than the occurrence of asthma exacerbations. Now, this model, this new model for airways disease, this treatable trait model, is not only applicable in severe asthma. I believe that it's time we started thinking about the different traits that might be driving our patients' problems in less severe disease. And it's easy to see a very simple system where we organize treatment and thinking based on an assessment of the 2 dominant treatable traits. On the y-axis, the risk of asthma attacks as a result of active type 2 eosinophilic airway inflammation, which can be identified using biomarkers. And on the x-axis, symptoms as a result of airflow limitation, which requires assessment of spirometry. And you can see that you would offer very different treatment approaches in patients who had discordance of risk of exacerbations and symptoms. With a bronchodilator heavy treatment approach in patients with symptom predominant disease, and an anti-inflammatory heavy treatment approach in patients who had inflammation predominant disease. Now, this approach, I think, is already happening. So the GOLD 2020 and 2019 guidelines and the GINA 2020 severe asthma guidelines and the 2018 guidelines already recommend a treatable trait-based management approach for COPD and severe asthma. It's becoming clear that we have clinically accessible, very useful biomarkers of type 2 airway inflammation, and they have established prognostic and predictive value, which I'll discuss. And finally, GPs who look after the bulk of patients with obstructive airways disease are very good at biomarker-directed management. In fact, they do this incredibly well for cardiovascular risk reduction, where they delivered a 70% reduction in mortality over the last 10 years in the UK. The two biomarkers I think will be most helpful in clinical practice are the blood eosinophil count and exhaled nitric oxide. And on this slide, I've shown the relationship between these biomarkers and the risk of asthma attacks in patients with mild asthma, moderate to severe asthma, and exacerbations of COPD. Now, if you look at mild asthma, this is a reanalysis of the novel START study published last year in the New England Journal of Medicine. This is a group of patients who have mild asthma on as-needed bronchodilators, short-acting beta agonist only, who were randomized to one of 3 different treatments for 12 months. And what I've shown here is severe exacerbations over that 12 months by treatment group. And I want you to focus on the blue group, the group that were given as-needed salbutamol, and the brown group, who were treated with regular inhaled steroids. And what you will see as we move from low to high eosinophil count, there is a 5-fold increased risk of asthma attacks in patients with higher blood eosinophil counts compared to lower blood eosinophil counts in those that are on as-needed salbutamol. And this excess risk associated with eosinophils is completely removed in patients who are on regular inhaled steroids. If you look at the bottom right, there's a very similar story in patients with COPD. You can see the risk of exacerbations increasing progressively with increasing blood eosinophil counts, and the benefits of an inhaled steroid getting progressively greater. And it's also the case for biologic treatment in moderate to severe asthma. You'll see in the top right that patients who have high blood eosinophils and high FeNO have approximately double to 3 times the increased risk of asthma attacks over the next 12 months, even though they all have moderate to severe asthma, high symptom scores, and poor lung function, and that the benefits of either treatment with mepolizumab or dupilumab are greatest in patients who have high blood eosinophils and FeNO. So these biomarkers really do identify risk, but crucially, they identify risk that can be modified with treatment. And that's important for a clinician. Now, in IMPACT, which was a study looking at triple therapy in chronic obstructive pulmonary disease, this was a huge study involving 10,000 patients. The relationship between the risk of exacerbations and the blood eosinophil count was particularly compelling. I want you to focus on the green line, which is patients who are on dual bronchodilators, that's UMEC vilanterol, and you can see the risk increases progressively as we move from low to high eosinophil counts, and that this eosinophil-associated risk of exacerbations was not seen at all in patients who were taking inhaled steroids. So a very beautiful, I think, illustration of the predictive power of blood eosinophils. And crucially, they identify risks that can be modified with treatment. And now GOLD in 2020 and 19 recommend that the blood eosinophil count is used to identify patients who should be started on regular inhaled steroids to prevent exacerbations. There's also increasing evidence that if you use biomarkers of eosinophilic airway inflammation as your treatment target, that is, you aim to normalize exhaled nitric oxide, you get better outcomes than if you target symptoms, which may or may not be related to type 2 airway inflammation. This is a meta-analysis from Petsky, published recently in Thorax, showing a 40% reduction in exacerbations in patients who are treated with exhaled nitric oxide or FeNO-guided steroid treatment. Now, I want to finish this section by talking briefly about the CAPTAIN study. This was a phase 3 randomized double-blind 24 to 50 week active control parallel group multi-center superiority study in patients with asthma that was uncontrolled despite LABA ICS. And the focus was to look at 2 treatment options, the addition of a long-acting antimuscarinic, UMEC, or doubling the dose of inhaled steroids. And you can see that there were 6 treatment groups when you look at the appropriate controls, each consisting of around 400 patients. So this was a large study. Patients entered into a run-in period during which they had open label ICS LABA in the form of Seretide, and then in the form of Relvar. And you can see that we have the option of comparing doubling the dose of inhaled steroid with addition of long-acting antimuscarinic agents. And crucially in this study, blood eosinophils and FeNO were measured before randomization, giving us the opportunity to investigate whether these biomarkers were associated with the treatment responses. Now, I'm showing here the impact of doubling the dose of fluticasone furoate by blood eosinophils on the left and by FeNO on the right. And you can see the effects on FEV1 on the top graphs and on moderate to severe exacerbations on the bottom graph. And the signal is very simple. In patients who are treated with an inhaled steroid containing treatment, so triple therapy or Relvar, the higher dose steroid worked better in patients with higher blood eosinophils and in patients with higher FeNO. And this was the case for FEV1 and moderate to severe exacerbations. So this biomarker of the treatable trait type 2 eosinophilic airway inflammation identified a group who would do particularly well with doubling the dose of FF. And this seemed to be the case whether it was on top of a LAMA containing regime in triple therapy or on top of just a LABA in LABA ICS therapy. In contrast, if we look at the effects of adding UMEC, and here we show the data on the high dose UMEC, the effects on FEV1 and exacerbations were completely unrelated to the blood eosinophil count and FeNO. Notice also that the profile of beneficial effects of UMEC was different to the profile of the double dose ICS, with a greater effect on lung function than exacerbations. So it looks like a treatable traits-based approach is applicable right now using simple biomarkers of eosinophilic airway inflammation. And I suggest that if your patient, and it doesn't really matter whether they have asthma or COPD, is not meeting the goals of therapy, that is improved symptoms, lung function, no exacerbations, how you respond to that depends very much on whether they have raised biomarkers of eosinophilic type 2 airway inflammation and whether or not they have airflow obstruction. And you can see that your treatment algorithm will differ in these different groups as set out in this algorithm. One of the great benefits of a treatable traits approach to airways disease is I think it will draw a very sharp focus on patients who don't fit well into this schema. So what about patients that are having attacks or symptoms who don't obviously have eosinophilic airway inflammation? What could be going on there? Could they have neutrophilic airway inflammation, perhaps driven by airway infection? And what about patients that have symptoms that are not obviously linked to airflow limitation? I see an enormous number of patients with chronic cough and a heightened cough reflex. And I think if you adopt a treatable trait-based approach, you will identify these patients early before a fruitless escalation of asthma treatment and potentially to the point where you might be doing iatrogenic harm to the patient. I thought this study recently from the Newcastle group in Australia was amazing, the Amazes study, which showed that long-term low-dose azithromycin given to patients with moderate to severe asthma reduced exacerbation rates by some 40%. The benefits were seen in type 2 high and type 2 low patients, indicating that it was modifying a pathway that is distinct from type 2 airway inflammation. And benefits seem to be larger in patients who had positive sputum cultures. Now, if you look at a recent paper in the European Respiratory Journal by the team, which is shown on the right here, you can see that the benefits of azithromycin were very clearly linked to the presence of Haemophilus influenzae in sputum. This was quantified using copy numbers per mil, using a quantitative PCR-based method. And you can see in patients not treated with azithromycin, the risks of exacerbation increases progressively as the bacteria numbers increase in sputum. And this relationship was not seen at all in patients on azithromycin. So here we have potentially another treatable trait with a useful biomarker. So I'm going to finish there. I hope I've convinced you that a treatable trait-based treatment strategy is radically different to our current approach. The indications for treatment is the presence of a trait, that is a biological process, rather than potentially unrelated symptoms or risks of exacerbations. And the goal of treatment is normalization of the biomarker, not suppression of potentially unrelated symptoms and or exacerbations. There's now compelling evidence that the two established treatable trait-based approach is superior to current guideline-based management in asthma and COPD. It looks to me eminently feasible in non-specialist care where there's particular expertise in biomarker-directed treatment. One of the benefits of this approach is that it would lead to a focus on non-pulmonary and behavioral lifestyle traits, and we'll be hearing more about these shortly, in a more timely fashion. And it will facilitate, rather than obscure, the identification of new treatable traits, allowing us to begin addressing important unmet needs in obstructive airways disease. Thank you very much.
Well, thank you very much for the opportunity to be here today and to present this work. It's quite an honour. We've heard from Professor Augusti, who's very nicely presented the history of the concept of treatable traits. And he's presented some key publications that have first initially evolved the treatable trait concept and then continued to build on that. However, the treatable traits strategy has been a concept for some time. So what I'm going to do today is spend some time presenting some data around the approach and the efficacy. So I'll start with looking at, does this approach work in practice, and if so, how? I'll present some real-world trials of treatable trait strategies, and then consider some key implementation thoughts around how we can do this in different settings for different populations. So I'll start with this randomised control trial of a treatable trait approach in a severe asthma setting. This was published earlier this year in the European Respiratory Journal. we recruited patients with severe asthma from a tertiary care centre. They underwent a couple of visits and had a multidimensional assessment performed to identify the key treatable traits that were present in each individual. After this assessment, they were randomised to either a treatable trait intervention or to usual care within a specialist severe asthma clinic. The intervention was over a 16-week period, and their visits were defined according to the individualised treatment plan that was generated based on the number of traits and the type of traits. At the end of the 16 weeks, they underwent further multidimensional assessment as their outcome assessment. This is the intervention, and I won't spend too much time going through this in detail, but you know that the treatable trait strategy has 3 domains: pulmonary, extrapulmonary, and behavioural and risk factors. These are presented here in this quadrant. And you can see that for each of the different domains, there are targeted interventions that were initiated based on the traits that were present. There were key components of the intervention that involved, as I said, the multidimensional assessment, biomarkers or trait identification markers that allowed us to see what traits were present in each individual, followed by targeted therapy to those traits. And this was delivered using the support and facilitation of a case manager. While there are a number of different traits, you can see here what types of interventions were implemented. I will share with you an inflammometry algorithm that was also used. So this is where we looked at the different inflammatory phenotypes of the airway as well as systemic phenotypes. You can see that we looked at eosinophilic, neutrophilic airway inflammation as well as mucus hypersecretion, and systemic non-allergic inflammation and systemic allergic inflammation. And these were the targeted interventions for those traits. It was a small trial. We recruited 55 participants, 28 in the intervention group and 27 in usual care. You can see there was a predominance of females. They were around 52 years of age, had some airflow limitation, were obese, had comorbidities, poor quality of life, and poor asthma control. The multidimensional assessment allowed us to see the number of traits that were present in each individual that was recruited from a tertiary care severe asthma centre. And the mean number was around 10. Here you can see the traits broken down into those 3 different domains, with the most number of traits seen in the extrapulmonary domains. We looked at the correlation between the total number of traits and SGRQ, and we found as the number of traits increased, quality of life decrement or impairment to quality of life also increased. This is important because it means that the more traits people have, the worse they are in terms of their quality of life impairment. For this study, our primary outcome was the quality of life using the AQLQ. You can see here that there was a significant improvement in quality of life in the intervention group and significant between group differences. Quality of life improved by 0.86 in the intervention group. Now, just a reminder that the minimal clinically important difference is 0.5. And we saw no change in the usual care group. We did a responder analysis to look at the number of people that achieved the minimal clinically important difference. And we found that this was almost 56% in the intervention group compared to only 22% in the control group, giving a number needed to treat of 2.9. We also improved asthma control. So asthma control improved in the intervention group by 0.72 units. Again, the minimal clinically important difference using this tool is 0.5. Our responder analysis revealed that 50% achieved this difference compared to only 20 or 21% in the control group. So this study here was the first randomised control trial of a treatable trait intervention that was comprehensive in terms of targeting all of the traits. And in a severe asthma population, we show that it leads to significant improvements in health status, asthma control, and data not shown here also shows that there's a significant reduction in the number of unplanned GP visits. But does this approach work in other airway disease populations? So I'm going to share this study now, which was a proof of concept study performed in a COPD population prior to that RCT that I just presented. So this was a small study. They were older, they had more severe airflow limitation, quality of life impairment, comorbidities, and were slightly less obese or overweight rather than obese. The intervention was very similar in that it was a multidimensional assessment targeting those traits that I'd previously presented and then implemented targeting therapy after the assessment of the traits. And here I've shown the results of the COPD trial as well as the severe asthma trial side by side. The outcome here, though, is the SGRQ, which was the primary outcome in the COPD study. And you can see that there was a 14-unit improvement in COPD, very similar to severe asthma, which was 13 units. Now, just a reminder that the clinically important difference is only 4 units, so the magnitude of effect was quite large. You can see that even in the COPD usual care group, we actually didn't see an improvement in quality of life. We performed a similar responder analysis in this study where we saw that the proportion of people that achieved a minimal clinically important difference of 4 units in the SGRQ was significantly greater in the treatable traits population. For usual care, we showed that 32% improved, and in the treatable trait intervention, it was 82% that achieved this clinically important difference. So these data of these that gave a number needed to treat of only 2. So data from these 2 clinical trials shows us that if you apply a multidimensional assessment and targeted management in severe asthma and COPD that targets the treatable traits identified in each individual, that you can achieve significant outcomes that are far better than usual care. And those outcomes relate to quality of life, disease control, healthcare utilisation, and inflammatory biomarkers, which I haven't presented today. So this is important because it provides us with some real-life efficacy data regarding the approach. But I would like to now consider some of the considerations for implementing these approaches into practice. I've presented 2 studies of complex populations that are from a tertiary care centre. I've shown you that as the number of treatable traits increase, health status impairment increases. And I'm also going to postulate that in a primary care and tertiary care setting, patients are less likely to have the same number of traits as you would see in a more acute care setting. So I think one of the key considerations for thinking about how do you implement treatable trait approaches is to think about how the population differs across these spectrums and how the team that delivers the treatable trait interventions may also differ. So when implementing an approach in primary care, it may look very different to tertiary care. The other important thing I'd like to consider is what traits should we target and how do we achieve the biggest impact? And there's a few things that fit into these thoughts. One is around the prevalence, so how common and which traits occur in different populations. What traits lead to the biggest impact in terms of their disease progression, but also in terms of improving outcome if you treat them. And what traits are the highest priorities for patients. And this is important in terms of engaging patients into these interventions. So I'm going to address the first 2, prevalence and impact. And I'll do this by presenting some data from this study, which was data from the Australasian Severe Asthma web-based database. So this is a study that's conducted in Australia, recruiting patients with both severe asthma as well as non-severe asthma. And you can see the inclusion and exclusion criteria listed there. It was a good data set. We had 434 patients in the severe asthma group and 102 in the non-severe asthma group. And clearly there were differences in terms of the medication requirements as well as asthma control for the two populations. The severe asthma population looks very similar to the previous RCT that I presented. So we looked at the prevalence of different traits, and not surprisingly, we found that people with severe asthma expressed a higher proportion of traits than those with non-severe asthma. And this was consistent across the pulmonary and extrapulmonary domains. However, our key question was, what are the traits that predict future attacks? And because this was a prospective study, we were able to assess the traits at baseline and then each 6 months up to 2 years. And what our analyses showed was that for each additional trait that we identified in these individuals, there was a 13% increased risk of future attacks. So what were those traits that predicted future attacks? Well, being exacerbation prone, having previous attacks, was one of the most significant predictors of future attacks. Now that's been shown in other data sets. But other traits that predicted future attacks included depression, vocal cord dysfunction, inhaler device polypharmacy, interesting, which may be a reflection of severity, systemic inflammation, obstructive sleep apnea, eosinophilic inflammation, anxiety, upper airway disease, and underweight. And I think that these data are really important in terms of thinking about how we design and implement treatable trait approaches. If we can identify the traits that have the biggest impact on future outcomes, and in this case we looked at attacks, but it may be quality of life or disease modification, we may be able to target those traits that will give us the biggest bang for our buck in terms of improving outcomes. So where to next? I think it's important to actually have a look at treatable trait approaches in different settings and in different populations to determine which traits should be included in these approaches, and also those traits that lead to the biggest impact in outcomes, whether that be quality of life, attacks, or other things. So I'd like to end there and acknowledge my collaborators, my affiliations, and my funding bodies. Thank you.
Hi there, my name's Dave Leather and I work for GSK, and it's my job to summarise and wrap up this webinar. So a while ago, we ran an advisory board with external people that came up with this problem statement, and you had the chance to look at this while you were waiting to join the webinar. And I think that group of people came up with some interesting perspectives. The problem, as they saw it, was that many patients with common airways diseases suffer with symptoms and attacks that are avoidable. That's really the fundamental issue we're trying to fix with treatable traits. And because all patients are different, a personalised approach to assessment and treatment would help connect the right patient to the right treatment at the right time. The group also went on to say that this would give us the opportunity to make patients better, reduce costs and waste, and help develop new treatments, interestingly. We also said that in comparison with other equally common conditions like cardiovascular disease, progress has stalled, that we don't optimise the risk-benefit of medicines for individual patients at the moment, and that sentinel events like asthma attacks don't trigger appropriate action. So it's an interesting problem, and we've been hearing from our speakers today. And what have we heard? Well, firstly, we heard from Alvar that this is not new. This approach has evolved over a period of time and has already started to be adopted in places. From Ian, we heard that this isn't just theory, there is evidence now to support these traits. And those traits apply to pulmonary, extrapulmonary, and behavioural and lifestyle issues that Alvar described. Key to me is that traits are not just about biomarkers and pharmacotherapy, they're about the holistic treatment of a patient. And then we heard from Vanessa that implementation in secondary care is possible by a multidisciplinary team, and most importantly, it improves outcomes for patients. This is a really interesting topic, and it made me think of where do we go next? And I guess one key question that we're going to hear is, will this be possible broadly? And a common response I hear is, this just will never work in primary care. it's too complicated. So I thought it might be worth looking at an analogue, an example we could pick out to say, well, can primary care physicians deliver a composite approach to disease management? And the disease I picked is cardiovascular risk. So this isn't an exact analogue, it's a risk management strategy, but it does share some common themes with treatable traits approaches in respiratory disease. There are key modifiable traits, and there are non-modifiable traits that drive risk. And in the case of cardiovascular disease, these have been put together as a composite in risk management tables. What's interesting to think then is what's been the impact of this in cardiovascular risk? And on this slide, I'm showing standardized death rates for cardiovascular risk in the United Kingdom. And what's interesting to me in this is that they have persistently reduced over time and they continue to do so. And very interestingly, over the last 10 to 15 years, at a time when death rates in asthma have really stalled, CV risk has continued to drive improvements in CV mortality. So you might say, well, that's because of public health. How good are primary care at delivering this traits approach in CV risk? Well, this study done in 2012 is very interesting. They looked at quality indicator markers of cardiovascular risk management in a variety of countries around Europe. It was a really well-performed study and they went into great detail. And I'm just going to look at the mean practice scores across the countries. When you look at these different traits that are being targeted in that, it really is clear that GPs are doing very, very well at managing this risk in certain areas, like antiplatelet therapy is nearly 90% successful of introducing appropriate antiplatelet therapy. Influenza vaccination, very clearly, very strong. And then the other more difficult ones like blood pressure control, but they're still doing pretty well, nearly 60% on target on diastolic blood pressure control. So why is that cardiovascular risk approach working in primary care? And I'm going to draw on my experience as a GP. I was a GP for 14 years in the UK. And when I was thinking back to that, prior to the large mortality trials in the mid-1990s, cardiovascular risk management in primary care was difficult. In the mid-90s, we started to get risk assessment tables. They brought clarity and direction to primary care physicians and allied professions. Why did that happen? Well, the traits and risk factors were very clearly laid out. Importantly, I think sentinel events triggered treatment decisions. Things like cardiovascular major events like myocardial infarction or stroke. Modifiable risks were the treatments, the targets for treatment. And there was a global uniformity and agreement around the approach. And I think also very importantly, there was no step down, there was little ambiguity. So where does that take us? What's the conclusion? Well, I think the conclusion from today's webinar is clear to me. The evidence has been evolving over time, but the compelling evidence is here now. It already exists. There's really compelling evidence about implementation and its impact. The second point for me is we should learn from cardiology and other disease areas and work at further developing a primary care approach focusing on implementation. And I think all of the speakers in today's webinar would agree with me in saying it is time to move now from discussion to action. Thank you very much for joining the webinar, and I'd like to thank our speakers too. Please do join us for the live Q&A we're about to have, and also please join us in the chat room later for further discussions where we can have an active and exciting dialogue.
Okay, well, thank you very much. While we wait for some of the questions to come in, I'd just like to kick things off. Vanessa very clearly showed that many patients, in fact, the majority of them, have a lot of different potential treatable traits. So if I can start off with Ian, if you have a patient who's got many traits, I mean, how do you prioritize which ones you're going to deal with, or do you deal with them all at once?
Yeah, well, I think there's a key question and a good question as well. I tend to focus on what I call the dominant treatable traits. They're so influential that potentially other traits may be related to them. And it's not entirely clear until you remove that trait how much of the clinical problem is due to it or not. So type 2 airway inflammation is clearly a critically important trait driving exacerbations, but also driving the need for oral corticosteroids, which may in their own right cause problems which everyone will be familiar with. And taking that trait away can have a very big impact in the right patients. We've learned that from the type 2 biologics. Clearly, airflow limitation is another important one. Cigarette smoking is really crucially important. I think obesity would be up there as well. So we could prioritize these traits, and I'm not sure there would be much disagreement between us if we did that.
Vanessa, anything to add to that?
Thanks, Neil. Maybe I need to think about what traits actually have that impact as well in terms of which traits predict future outcome. And we do have some data from a number of studies that inform us around that. And the other thing to consider is what traits are you going to get patient engagement in? So Ian mentioned smoking, for example, and that's really important, has a really important impact, but might not be the first one that the patient's ready to engage in. So it might be worthwhile looking at other traits and gaining some wins before you then address the things that they might be less likely to want to approach.
Yeah, I mean, I agree. I think, for instance, I think dysfunctional breathing and anxiety are very difficult to address, but if you deal with like the type 2 inflammation, you've gained patients' confidence when you go to those more difficult ones. There's a question which has come in, which I find a little difficult, but it says, should we add a fourth class of treatable traits, namely etiology, looking to the azithromycin results? So, Alvar, I wonder if you would like to address that.
Well, my answer would be ideally, yes. It'd be great if we know precisely the etiology of all these traits, because then we can address them therapeutically much better. And Th2 inflammation might be a good example for that. So if you think that your patient has, for instance, chronic bacterial airway infection, and you know what bacteria is there, yes, I think you should treat that, because that would be the ideal condition. In practical terms, the problem is just the opposite, that often we do not know the etiology. But I would say that yes, no doubt, if you know the etiology, much better. I don't know if you agree, but I think that's clear in my mind.
Yeah. Could I ask Vanessa, I mean, one of the things that people worry about is that this approach may increase costs. Now, to my mind, it would probably decrease costs, but have you had any discussions with your payers or your managers about sort of cost effectiveness of this approach?
I think that's a really important question, because, and if you think about the health economics, you might agree that initially the cost may be increased because you may require a few extra people in the team to deliver these strategies to address the traits. However, what I think will happen is that eventually, then you'll get a cost gain from the actual impact you have on outcomes with reduced healthcare utilisation. We're currently undertaking a health economic evaluation of the severe asthma study that I presented. So I think that will be some informative data in terms of longer term impact on health economics.
There's a question come in, which I'll address to Ian. It says, the treatable trait approach isn't what physicians have been doing anyway with common sense for a long time. So basically, is it anything new?
Well, I agree with that. This is a common sense. The difficulty is that it's not what the guidelines say, and we need to somehow close the gap between guidelines and what we're saying. And arguably, there's been a rather paternalistic approach from us, this can't possibly be done in primary care. But if the cardiologists had taken that view 10 or 20 years ago, maybe they wouldn't have got anywhere. We've got to aim high. We've got to, I completely agree with David's comments. We've got to be much clearer in what we say. And if we can do that, I think, primary care, who have done such a fantastic job in other areas, will really deliver better outcomes, and also, help us much more clearly identify what we can't do in airways disease. At the moment, we're chasing the symptoms far too often and not asking what are they due to.
I'll come back to that, identifying what we can't do in a minute, but I'd like to get Dave Leather's view on this as a primary care physician by background. Is it what GPs have been doing already, and how do you think they will take it?
I think it is. I was discussing this with Professor Mike Thomas, Professor of Primary Care Medicine, in preparation for another meeting, and we were having this discussion and saying this really is what certainly respiratory interested GPs have been doing. Maybe not with clear guidance in the way that Ian suggested from guidelines, but also I think almost taking guidelines and simplifying it themselves. So looking for those traits they can treat, in particular behavioural traits, the obvious ones like smoking, poor inhaler technique, attention to adherence, which of course primary care is ideally placed to do. And I think that the prospect of looking at type 2 airways inflammation will be a simple concept for GPs to grasp. And I think they'll easily understand it. I think it's a far simpler paradigm than a step up, step down approach, which, to be honest, is a bit baffling, I think, in primary care. I know we've had this discussion that there are a few conditions where you treat risk, where you do reintroduce risk by reducing treatment. So I think by identifying the traits, it makes it logical, it makes it easy to follow, and I think it will drive big improvements if we go this way.
Thanks very much. One of the things that I've noticed, having been doing a severe asthma clinic up until 2013, and then leaving that to join GSK, and then coming back to doing severe asthma clinic because of the pandemic, is that a lot of the patients with type 2 inflammation are now being treated with biologics and doing really well. And therefore, they've almost been taken out of the difficult asthma group. And what you're left with is the type 2 biomarker low, and patients were non-adherent, and patients with dysfunctional breathing and vocal cord problems. So do you think that when we look at this treatable traits approach, it will evolve over time in terms of the predominant traits that we're worried about? I mean, perhaps Vanessa could start, because she's very much at the coalface of dealing with these type of problems.
I think taking the severe asthma example is a good one, because despite the biologic treatments, people still do have a residual burden from their severe asthma disease. And those traits that you mentioned, for example, the dysfunctional breathing, the vocal cord dysfunction, obesity, may be real contributors driving that residual burden, and it may be related to other mechanisms. So I think it's really important, even though we have these highly effective treatments, to also consider these other treatable traits that can then potentially lead to improvements in that residual burden that people are experiencing. So I think that's still going to be a really important aspect of care in a severe asthma population.
Yeah, I agree. I think those that are difficult to treat, and often we haven't got access to enough physiotherapy and psychology time to deal with those things. I don't know, Ian, your view on that?
But I think saying to the patient that really this is the primary focus. I've analysed the problem. We've removed what we can remove. We now have to turn the focus to these more difficult things, like smoking cessation and weight loss. I think the patient may accept that, and hopefully you'll have them on your side. But yes, I mean. If it's clear that that's really the only option here, we've done everything else. that we've got to start making progress in these more difficult areas.
Right.
And Neil, can I just pick up on a point you also made that relates to one of the previous questions, that you had commented about limited access to, say, multidisciplinary teams. But I think that's really important in terms of systematizing that approach. So the question was asked earlier about, is this what we usually, like what we do anyway, and is it common sense? But the treatable traits model of care or strategy allows that systemization of care involving multidisciplinary health professionals to be able to address those numerous traits that are present in individuals.
There's another question come in. I'll address this to Alvar. It says that there is a disparity between the treatable traits most strongly related to a clinical outcome and the treatment for that treatable trait that has the largest effect. How do you work with this in real life? So I think it's saying you might have a treatable trait that's there, but it's not got the treatment that's strongest. So I suppose it's how do you square up the trait with the treatment?
Well, I'm not sure I understand the question, because
I didn't quite understand it either, but I thought you might.
Because I'm not sure that that's a correct statement. Often, an obvious treatable trait has a very big effect if you treat it. I mean, T2, airflow limitation, whatever you want. A different issue might be, what do you do with traits which are currently untreatable or poorly treatable? That's a different issue. I think that that's a problem, but at the same time, that's an opportunity, because it highlights and underlies that there are traits that might be relevant for which we do not have currently appropriate treatment. And that's a target for research, clearly. Yeah. That would be my answer.
Yeah, no, I agree. And I think the Haemophilus data that Ian showed is very promising for that, because I think, if we could target where we use azithromycin better, I think that would be a tremendous advantage. I'm going to finish up with one last question. And with the pandemic, I can't resist not having a COVID question, but a lot of us now are working, remotely with virtual clinics and by phone and by TC. How is the treatable traits approach working in that virtual world? And I think we'll go around everyone. We'll start off with Alvar, as you're on the screen at the moment.
Well, in my experience, I would say that it can work still pretty well. It depends on the quality of the communication that you have with the patient, even if kind of telematic. So I don't see why it should not work. Of course, it's not the same thing as having the patient in your office, but still can work. And I would suggest for people listening, if they have not done so yet, that they go to the webpage of GOLD. And GOLD has produced a short document where some recommendations are provided for televisits for patients with COPD in the COVID times. So yes, it's not the same thing, but it should not be, in my opinion, a limiting factor to apply the same reasoning.
Dave, from a primary care perspective?
Yeah, I mean, I'm obviously the pandemic has driven this massive change in the way of working, and what I'm hearing in primary care is that this change could well be here to stay. It's made things very economical. We don't get missed appointments. The doctor can be very much in control of his time and the consultation. And I don't believe that the treatable traits approach can't be delivered in these circumstances. The majority of primary care, we're not doing active investigations during the consultation. We're often looking at historic blood tests, etc. Pheno might be different, but at the moment, Pheno is really in the hands of enthusiasts. But certainly, I think treatable traits is eminently treatable, since so much of what we're talking about actually is behavioural and not just pharmacological. And the we can still intervene. And I hear from practice nurses as well that they're having good success in terms of things like adherence, inhaler technique. And of course, we're going to see an explosion of artificial intelligence aids to inhaler technique, etc. too. So it's a changing world.
Ian?
Yes, I would say that at least 75% of our severe asthma patients can be handled perfectly well on a remote consultation. The difficulty is you can't get contemporaneous measurements, and that's important for spirometry and pheno. But a lot of the other data is, there's lots of it available historically. And it can be very valuable to go through the records and, and try and tot up what potential traits there are and what the evidence for them is. And once you've done that and you've got a management plan, the likes that Vanessa discussed, you can review progress remotely. I think it's worth seeing. One of the difficulties with airways disease, of course, patients have events, they have episodes, which maybe we should realign our clinics so that they're much more responsive to these episodes, because their nature is not always entirely clear. It can be really helpful to see people, when something's happening. So that's very much what we're thinking will be the result of COVID.
Yeah, and certainly during the clinics, you can get a long way with the blood tests, and I'm impressed by how stable. I mean, people say, they're very variable, but I'm impressed by how stable they are. If you're biomarker low, you remain biomarker low. Vanessa, you get the penultimate word.
Thanks. I agree with what's been said, and I think that it's almost creates an opportunity because we've been forced to operate in this way to enhance implementation of a treatable trait approach. And as time goes on, as Dave said, the information technology is only going to improve more and more, so our opportunities will increase.
Yeah. Thanks very much. Well, I'd like to bring this symposium to a close. I think there's one other area which we didn't cover, which I think is going to be increasingly important, and that is identifying preventative treatments and vaccination. And that's obviously very topical, and I think will increase in topicality as we roll out the COVID vaccines. But I'd like to thank all the speakers. I'd very much like to thank the technical team who made this work seamlessly. And I think Vanessa gets the prize for the most beautiful house plants. So thanks very much, and I hope the rest of the meeting goes very well.
Thanks very much. I just want to end by saying if you do need any further information about GSK products and their prescribing information, this is available on the GSK webpage or from your GSK representative. Thank you.